Good morning. This is Median Ali. I'm going to present in this lecture a quick review of coronavirus and COVID-19 diagnosis, treatment, prevention, and other aspects of care. Let me start by saying we don't have effective treatment yet for COVID-19 that approved by the FDA. We have a couple of treatments that emergency use right now. We don't have a game-changing treatment that would make a huge impact on morbidity and mortality, although there are some encouraging reports about steroid and remdesivir. So if for prophylaxis, for prevention after exposure, we don't really have a treatment available. The studies about hydroxychloroquine did not show that it was effective in preventing the illness. If you have a mild case to moderate cases, which include fever, maybe some X-ray findings with or without dyspnea, these patients usually are not requiring oxygen. Some of them, or most of them, actually can be treated at home. There is no treatment recommended, but you can involve in one of these trials with favipiravir and AT527. There are randomized controlled trials going on for both. If you have a severe disease which most of the patients we see in the hospital, they're usually requiring oxygen, they have dyspnea, their saturation below 94%, they have radiographic findings, and these patients, we do recommend remdesivir and decadron. Remdesivir based on the emergency use authorization, and then dexamethasone 6 milligram IV or oral daily for 10 days. You could consider also convalescent plasma, and you can consider anti-IL-6 through a trial, the randomized controlled trial. For patients who critically ill, severe COVID-19 disease, they are like vented, multi-organ failure, ARDS, we still recommend remdesivir. Of course, you have to be careful. These patients tend to have renal failure and liver failure, so you have to meet the what you call partners criteria, which we'll talk about, and strongly consider dexamethasone. You can also give convalescent plasma, and you can give IL-6 inhibitors such as revolizumab. For pregnant patient with severe COVID-19, you can also consider remdesivir through the emergency use authorization, and also dexamethasone can be used in these kind of patients. Now, on the other hand, I'm going to mention here the medication that did not show efficacy. There is no data, no evidence that using ACE or ARP as prevention or treatment for COVID-19 is indicated. But if your patient is already on these medications, you can continue. You don't have to stop them. You don't have to hold them. There is a study going on to see if there is any efficacy in prevention and treatment. Hopefully we'll know some results soon. Then the azithromycin, there is no enough evidence to support using it for COVID-19. I do recommend against using it routinely for COVID-19 patients unless you have evidence of bacterial pneumonia or other indications that justify using azithromycin. Statin also not indicated unless the patient is already on it. Hydroxychloroquine, the data showed there is no benefit. Interferon, there is not enough evidence to support using it. There are a couple of trials that are going on, but I don't think the data from these trials are enough to support wide use. IVIG, it's very unlikely that we will have a pool of blood donor that enough to create enough IVIG. Lopinavir and ritonavir, which is used for HIV, the trial showed no evidence of no benefit. How about ibuprofen or non-steroid anti-inflammatory drugs? Obviously, they don't have rule in therapy. There was concern that may worsen the disease. There is no evidence of that, so we really don't have recommendation whether against it or for it, but there is no problem using it based on the evidence we have, unless there is a contraindication otherwise. Ribavirin, there is no evidence to support it. There are a couple of trials of using ribavirin, interferon, and other antiviral medication in a combination, like what you see with HIV. And finally, zinc and vitamin C. Also, there is no evidence to support that low or high, or limited evidence to support low or high dose of vitamin C or zinc in for prevention or treatment of COVID-19. Therapies for COVID-19 now, I think we don't really have a game changer medication that will say that, oh, definitely can treat you. We have some medications that showed some efficacy in decreasing mortality, hospital stay, and I'm going to talk about a couple of them. The first one is remdesivir. There is a preliminary report that was published in a New England Journal of Medicine. It's a double-blind, randomized, placebo-controlled trial of IV remdesivir in adults with COVID-19 pneumonia. A total of 1,063 patients underwent the treatment. They were randomized to receive either remdesivir, followed by initial dose was 200 milligrams the first day, and then 100 milligrams daily for 9 days. The primary outcome was time to recovery, defined by either discharge from the hospital or hospitalization for infection control purposes only. So the preliminary data showed that the time to recovery was 11 days on the remdesivir compared to 15 days in the placebo group. That means decreasing the number of days in the hospital by 31%. There was also some mortality benefit. At that time was not statistically significant. But on July 10th, the company that produces remdesivir, they said in a trial of more than 1,100 patients, remdesivir was associated with improved recovery and also a 62% reduced risk of death compared to standard care. So there was not just decreased hospital stay, but there was about 62% reduced risk of death. The study also showed 74% of remdesivir treated patients recovered by day 14 treatment, compared with 59% of the patients receiving the standard care. So I would recommend remdesivir for patients who have saturation below 94%, for patients who have pneumonia, whether they are on the vent or they are not. I do recommend using remdesivir relatively early in the course of the illness when the criteria are met. Certain COVID-19 patients seem to do better on the drug than others, usually Black patients. They do better. Also found those younger than 65 better than the older ones, and also the patients who were not yet on the ventilator, either on room air or oxygen. Just to give you some idea about the price, it's about maybe between $3,100 to $4,000 for the course of treatment, the 10 days course. Now, you know, the company stated that it's justified because you really decrease the hospital stay significantly, and you decrease obviously mortality and the need for mechanical ventilation. So again, the indication, adult and children weight more than 3.5 kilograms, They are hospitalized. Obviously, you cannot do it outpatient. Saturation below 94%. Being on mechanical ventilation or ECMO. You should not give it if your liver function tests are significantly abnormal, like ALT 5 times the normal. For patients with GFR less than 30, kidney failure, you could use it on individual basis. We do not recommend using remdesivir for outpatient or patients who are really with mild disease, or just they have a positive COVID-19 without really other like a low saturation or hypoxia. So just to remind you about the pathophysiology, again, we talked about how the virus, the SARS-CoV-2, comes in contact with the ACE2 receptor, and then it gets into the inside the cell, and then it takes over the ribosomes and starts translation, making copies, and the RNA-dependent RNA polymerase is the enzyme that is responsible of translation and replication, and this is where remdesivir works. It suppresses this enzyme. If you're asking about hydroxychloroquine, it is working on the endosome maturation as endosome maturation inhibition. So this is when the virus gets inside the cells before the virus release the RNA. The hydroxychloroquine works here. If you are asking about the monoclonal antibodies, it works here by inhibition of viral host interaction by working against the spike protein on the virus membrane. And just give you some idea about the pathophysiology. I think the future of treatment of COVID-19, in my opinion, it will rely on more than one antiviral or one medication. Because most of the treatment available now is focusing on one aspect of the virus entrance of the cell or replication. I think maybe we need a combination or a protocol that would attack the process at different stages. And along this line, this is a study of using combination of interferon beta and lopinavir/ritonavir. We know that previous studies with using this lopinavir/ritonavir was not very promising, but in this study they found actually using the combination was relatively effective in reducing symptoms and the duration of the illness. Of course, this is not a big study, it's not really breakthrough study, but again, it's suggestive that maybe a combination treatment would be more effective. There is another study I did not include it here about using interferon beta in inhaled form, and there was a significant reduction in mortality. Unfortunately, I don't have the full report. It was more like a press release. There is another also study about using nasal drop of interferon beta for healthcare workers for prevention of COVID-19. That also showed some promising results. Now there is a focus on using inhaled form treatment or maybe even nebulized form of remdesivir, and the idea is maybe we can give it as outpatient. So it would really make a huge difference if we can provide a treatment that patient can take as outpatient and prevent even the hospitalization, prevent the overwhelming factor of the healthcare system. So when we heard about the cytokine storm, right? Like, so when there is, again, we go back to the SARS-CoV-2 here, attaching to ACE2 receptors, activating the alveolar macrophages, the dendritic cell, then you have the production or the release of inflammatory mediators, including IL-12, IL-1, IL-6, and tumor necrosis factor, which will induce more white blood cell recruitment, and this will induce more cytokines. The IL-6 would cause leak into the circulation and cause the systemic multi-organ pathology, and this is the kind of the mechanism of the cytokine storm, which can cause tissue injury, ARDS, endothelial damage, and capillary leak syndrome. So it would be nice if we can find something that potentially can stop this cascade and the damage that caused by the reaction of the immune system. So cytokine storm plays a major role in the progression of COVID-19. So it would make actually sense that using IL-6 inhibitor, which is a key cytokine, as a way to inhibit the disease and slow the progression. So tocilizumab can block the downstream signal transduction by binding to MIL6R and SIL6R, and so it actually play a role in treatment of cytokine storm caused by COVID-19. The preliminary studies, it shows that tocilizumab maybe actually has influence on decreasing the need for mechanical ventilation and the survival outcome. Also, there was some improvement in oxygenation and other inflammatory biomarkers. Now, be aware of the side effects, including neutropenia, thrombocytopenia, and risk of serious infections as well. When it comes to hydroxychloroquine and chloroquine, I'm trying to stay away from politics. Unfortunately, that has been injected too much with using these medications. I'm just going to stick to the science that we have available, and the science is clear, and it says there is no indication to give it unless it's part of clinical trial. There is enough evidence that it should not be used as a prophylactic treatment, prophylaxis, or as a treatment for COVID-19 patients. There is also some potential for harm. We do have two major studies published in New England Journal of Medicine. I put the link here for you. This is a randomized trial, did not demonstrate any benefit for post-exposure prophylaxis, and this is also a hospitalized patient with mild to moderate disease, and there was no significant difference in 15 days clinical status outcome among a group that received hydroxychloroquine compared with standard care. I think the guidelines now, it says just use it only as a clinical trial, and that's the reason the FDA canceled or revoked the emergency use authorization on June 15. The European government also removed it, halt the use on May 27. Treatment with plasma for infectious diseases is not new. Actually, it's been in use for more than 100 years. The first use was reported in JAMA in 1893. Now, think about convalescent plasma as a bridge, because it's really not the standard treatment. It's just trying to buy some time by giving the antibodies. It is probably more effective if you give it early in the course of the illness. If you give it late when there is ARDS and the patient is critically ill, it's unlikely to work, because what it does, it gives antibodies to the patient and may affect the replication of the virus, limiting that. If the patient is already reaching that what you call cytokine storm, and inflammatory process is taking over the lungs, it's unlikely that will be effective. Now, obviously, if the plasma would be more effective if it does have high titer of anti-COVID-19, The problem is we really don't know how long these antibodies would live. And, for example, if you get plasma for a patient from March and now it's already July or August, the problem, do we know how much antibodies still like there, and whether they are still effective? There was a large study which was published in Mayo Clinic proceedings, and they had 20,000 hospitalized COVID-19 patients who received transfusion of the convalescent plasma, and they found the treatment to be safe, and so just giving it to people early in the disease may be beneficial. 7-day mortality declined to 8.6 compared to 12% in previous safety study of the first 5,000 transfused patients. There were no serious adverse event, less than 1%. Beside the convalescent plasma, we have the IVIG, which is intravenous immunoglobulin made of pooled IgG from convalescent plasma. There's also monoclonal antibodies targeting SARS-CoV-2, and actually I have a lot of hope on that. There are a couple of trials now going, and we may hear results by September or October. And this is the monoclonal antibodies. Potentially, they could be the bridge that we are looking for to help our patients until we get vaccine. So what they do in this monoclonal antibody, they clone antibody genes from COVID-19 induced B cells to try to determine which one accounts for a convalescent plasma donor's effective immune response against SARS-CoV-2. There is, I think, Eli Lilly, the drug company, pharmaceutical company, they are testing one of these monoclonal antibody. They call it LY-CoV555. It's actually a potent and neutralizing IgG1 monoclonal antibody, and it's directed against the S-spike protein on the top of the virus. And what it does by targeting the S-spike, it actually prevents the virus from entering the cell. They are doing phase 1 trial, and I think we may hear something, maybe hopefully some good news by September or October about the efficacy. There are 2 other companies, I think, running similar testing about monoclonal antibodies. There are a couple of studies about using 2 of monoclonal antibodies, or about a cocktail of monoclonal antibodies targeting different parts of the virus. Again, if you go back 100 years, you will find that controversy about the mask was there. Again, lessons from history that we tend to forget really quickly. This is actually a very fitting slide, because we are, started a couple of weeks ago, the baseball season, and just put this picture with the baseball stars wearing mask during the game. As you guys know, our public health recommendations, our CDC recommendation, they are now they've been targeted from the beginning with the misinformation campaign, and they were politicized to a degree that we've never seen before. There is a study, an event study, examining changes in daily county level COVID-19 growth rate between March 31st, 2020 and May 22nd. And mandating face mask in public was associated with a decline in daily COVID-19 growth by significant percentage. And the estimates suggest as many as 230,000 to 450,000 COVID-19 cases possibly averted by May 22nd by mandating the mask. Now, I know many states now, they start mandating the mask after we have a huge surge of cases As we talked about, in the last 2 weeks, there are million new cases reported in the United States. It's not just the mask, obviously protect your other people if you're infected, but also can protect you from other people if they are infected. There's also economic impact. A team of economists, MDs, and other scholars at Yale University, they estimated that a mask that blocks 10% of the viral particles produces a benefit of between $3,000 to $6,000 per person for our economy if the person wears the mask on regular basis. So there is a huge impact, a huge benefit, even from economy standpoint. The other factor that is very important when we talk about wearing face covering is the viral load. The viral load is the number of virus particles per volume of person's blood or sputum. The higher the person's viral load, the more likely the person is to become infected with COVID-19, and the more likely will have severe cases. Although there are some studies now showing that a relationship is not as strong. The super spreader events usually have much higher viral load. So actually the masks, even the one blocks 10% of particles, would lower the viral load significantly, and maybe to the point making it not sufficient enough to infect other people. And even if they are infected, they would not have as severe infection. So in one hand, it decrease the viral load to a significant degree that maybe the person is not infectious anymore. On the other hand, also, even if you get infected, you're getting less viral particles and maybe less severe disease. I think most of us remember the triad of Virchow, which includes endothelial damage, endothelial injury, hypercoagulable state, blood flow stasis. All of that would lead to thrombosis, and all these factors actually are present in COVID-19. We know by now that COVID-19 is associated with a hypercoagulable state, which is usually a reflection of the acute inflammatory changes. These patients usually have higher level of fibrinogen and D-dimer, and D-dimer is actually can be a good predictor of the risk for coagulation. The PT and PTT are usually modestly prolonged. There may be mild thrombocytopenia and sometimes thrombocytosis. So this is what makes it different from the IC. Here we have a more elevated D-dimer and less elevated PT or PTT in COVID-19 compared with the IC. Now, the risk of venous thromboembolism is markedly increased in these patients, especially if they get admitted to the ICU. And the case series that I reviewed, there was a prevalence of between 25 to 43% in ICU patients, in spite of having a prophylactic dose of anticoagulation. So we do recommend at this point all patients should receive prophylaxis unless there is a contraindication for that. There are some protocols depending on the institution. They have more aggressive anticoagulation with intermediate dose or even therapeutic dose for thromboprophylaxis, and obviously therapeutic dose is appropriate for patients with evidence of DVT or PE. These are from patient who died from COVID-19, and you could see the evidence of microthrombi, multiple microthrombi intra the alveolar septa of the lung. And this is one of the major findings in a lot of these patients who died from COVID-19. So in general, this is what we do recommend if you have low risk, meaning the patient has no evidence of DVT or PE, D-dimer is less than 2000, mild disease. You can just give the standard prophylactic dose depending on the kidney function. We recommend heparin if the patient is in renal failure, or Lovenox 40 milligram daily if the patient is not in renal failure. Now, there are some people who recommend doing a higher dose of prophylactic treatment for obese patients. So rather than just one size fits all, if the patient is obese, maybe do 40 milligram twice a day rather than once a day. And that some people save that to more the intermediate risk patients. So if the D-dimer is above 2000 and the patient has moderate to severe disease, I define the moderate to severe disease anyone honestly requiring oxygen. So if your patient is obese, requiring oxygen, and D-dimer is above 2000, I do recommend doing 0.5 milligram per kilogram twice daily. A maximum would be 70 milligram twice daily. If the patient's creatinine clearance less than 30, you can do the unfractionated heparin infusion with the PTT goal 45 to 65. If the patient is high risk, for example, if you have confirmed PE, patient is on CVVHD, the D-dimer is above 3000, I do recommend full anticoagulation. If the kidney function is normal or creatinine clearance above 30, you can do a full dose Lovenox, 1 milligram per kilogram twice daily. If the patient has renal failure, you can do the protocol for PE and or DVT with heparin drip. Causes of death from COVID-19. In our experience here, I think most people died from profound hypoxia and refractory ARDS. In these two studies, they included 33 individuals who died from COVID-19. And they found the most common cause of death in these two studies were to be pneumonia or PE. From pathology standpoint, diffuse alveolar damage, which we see with ARDS, was common, and inflammatory infiltrate consistent with viral or bacterial pneumonia was also present. And both studies, average age was mid-70, mostly men. Pre-existing condition was common, like heart disease, high blood pressure, obesity, and diabetes. And this is, I just want to mention, this is a case of a woman who had a transplant. She had severe COVID-19 complicated by ARDS, significant necrosis and damage to the lung, and eventually was on ECMO and then underwent transplant. Not sure about her condition right now, but I just want to show you how much damage you can get to the lungs caused by COVID-19. You can see this is the lung that was removed, and I mean it's very obvious that damage that it's hard to describe. One of the studies that changed the way we treat COVID-19 is the recovery trial from UK. They studied 2,104 patients, were randomized to receive dexamethasone 6 milligram PO or IV for 10 days. They were compared to about 4,321 patients who just received the usual care. And they found among the patients who received the usual care alone, 28 mortality was highest, and those who required ventilation 41%, intermediate in those patients who required oxygen only 25%, and lowest among those who did not require any respiratory intervention, about 13%. They found also dexamethasone reduced death by 1/3 in ventilated patient, and by 1/5 in other patients receiving oxygen. Now, there was no benefit if the patient did not require any oxygen or respiratory support. The concern now, everyone is using dexamethasone. We're going to have a shortage of dexamethasone. Well, if this is the case in your institution, you could use hydrocortisone 50 milligram IV every 8 hours for 10 days. You could use also methylprednisolone, the soluble 15 milligram IV BID for 10 days, or you can use only prednisone 40 milligram PO daily for 10 days. Remember, if you're also treating shock, we recommend hydrocortisone 50 milligram IV Q6 hours until improvement in shock, followed by the consideration of steroid dosing according to the recovery trial for 10 days. So we still have the same indication for using steroid in shock with patient COVID-19 as with other infectious diseases. Well, we showed that there is a benefit of giving steroid if you have moderate to severe COVID-19. The question, if you're already on steroid, does that give you protection? And actually, the preliminary reports suggest the opposite. The actually prednisone at dose more than 10 milligram daily is associated with high risk for hospitalization. The COVID-19 Global Rheumatology Alliance provider registry suggested that moderate to high dose steroid is actually associated with more severe COVID-19 disease. On the other hand, actually, the other biologic or targeted DMARD, other treatment for rheumatoid arthritis and rheumatoid diseases, were not associated. Were not like a Humira, like Remicade and stuff like that, were not associated with a higher hospitalization. Actually, there were fewer hospitalization among these patients. And in another study from University of North Carolina, they found that patients with IBD who were on systemic steroid, they have high risk for severe COVID-19 disease, along with age and comorbid conditions. But there was no association with a tumor necrosis factor antagonist for treatment of IBD. And this treatment would not lead to worsening COVID-19 outcome or severe disease. Let's talk a little bit about COVID-19 and the heart. Unfortunately, COVID-19 can damage the heart in different level. It can cause myocarditis like any other virus. The hypoxia associated with COVID-19 can cause hypoxic injury and type 2 MI. You can also get stress cardiomyopathy. We actually saw a higher level of stress cardiomyopathy based on some research, even in patients who did not have COVID-19. And you could imagine the anxiety that was associated with the pandemic as a potential cause of the increased number of stress cardiomyopathy. But COVID-19 itself can cause also a stress cardiomyopathy. There's also a report of ischemic injury caused by cardiac microvascular damage or epicardial coronary artery disease. We talked about the microthrombi in the lungs. We can have similar to that also in the heart. And finally, the systemic inflammatory response syndrome and the cytokine storm also can cause damage to the heart. So you can see there are different ways to cause damage by COVID-19. So this is illustration of some of that. We talked about myocarditis. The SARS-CoV-2 targets myocardial ACE2 receptors, and it can cause direct damage and inflammation in the heart muscle. Also, the release of the cytokines can cause indirect injury to the heart with a high concentration in critically ill patients with COVID-19. You can also get the microangiopathy with the highest level of D-dimer. Sometimes you may have what it looks like almost vasculitis-like mechanism causing cardiovascular injury. And finally, you could have myocardial infarction with a higher troponin caused by inflammation and viral invasion, causing the plaque instability and disruption. And in addition to that, the hypoxia can actually exacerbate underlying coronary artery disease and induce MI. Most patients with COVID-19 with evidence of MI, they still present with typical symptoms and signs of COVID-2 infection with fever, dyspnea, and infiltrate on the X-ray. Minority of patients with COVID-19 with evidence of MI present with cardiac symptoms. And so the presenting symptom could be chest pain or shortness of breath without really other classic symptoms of COVID-19. So you really have to have that suspicion, and depending on how the prevalence of the disease in your community, you may have you may need to check these patients for COVID-19 to make sure they get the appropriate isolation and you wear the protective PPE with caring for these patients. Um, COVID-19 and myocardial injury. Again, most patients with COVID-19 without suspected acute coronary syndrome with mild troponin elevation and without acute heart failure can be monitored without intervention, without cardiac cath. So unless you really have a high suspicion or you have a significantly elevated troponin, they have other classic symptoms, maybe you better watch them if they have just a mild elevation. According to a new cohort study which was published in JAMA Journal just last week, 100 patients were in that study recovered from recent COVID-19 infection. They followed this patient and they found there was evidence of ventricular dysfunction. There was a greater ventricular mass, and in 78% of the cohort, signs of myocardial inflammation by cardiac MRI were evident, and the findings were actually they correlated with the elevation in the troponin T. Two-thirds of these patients actually they did have a mild to moderate disease, so they recovered at home, and 1/3 were hospitalized. So that is really important in a way that when we say that cases are recovered, what do we mean by recovery? Do we follow these patients long enough to know if some of this cardiac damage is reversible or not, and whether there is some sort of chronic changes that put the patient at risk for congestive heart failure? Obviously, some of your patients who are infected with COVID-19, they have hypertension and they may be taking ACE inhibitor. So the question is, should you stop? Should you continue? Well, retrospective data analysis from United Health and Yale School of Medicine, they found that older COVID-19 patients with hypertension who are taking ACE inhibitors had actually significantly lower risk of hospitalization. Obviously, we need further research to confirm these results, but in general, now if your patient is on ACE inhibitor, they should continue the treatment if there's no contraindication. It is definitely not recommended as a prophylactic treatment for now, except maybe if it's part of a trial. We'll talk a little bit about the critical care management of patients with COVID-19. In general, most of these patients they are on low level of oxygen when they come, and then usually between day 7 to day 9 they start requiring high flow oxygen. Early in the course of the disease, back in March and April, unfortunately, with limited data, we started intubating these patients a little bit too early, in my opinion, and we ended up putting a lot of these patients on ventilator with a high mortality. So there is a obviously shift over the last few months to use other methods such as heated high flow nasal cannula and non-invasive ventilation like PIPAP to prevent progression to needing intubation. So in general, we do recommend starting with that rather than jumping for intubation. We also recommend restrictive fluid resuscitation unless the patient is hypotensive or septic. We also do what you call a wake prone position, which may help to redistribute the fluid and maybe improve the VQ mismatch. Now, if you do all these measures and it does not help, you may try the mechanical ventilation. If you do mechanical ventilation, you try lower tidal volume, like the network study protocol, 6 milliliter per kilogram. Try to make sure your inspiratory pressure is not too high, and conservative fluid management, and a little bit higher PEEP. So let's talk a little bit about self-proning. So if you have a patient who's requiring high flow oxygen, the patient is not in severe distress, the work of breathing is not severely high, the patient is maintaining okay, cooperating, does not have a contraindication, then you can ask the patient to, with help, maybe to lay on his stomach or her stomach. And the data from the self-proning are encouraging. It actually improves ventilation to the back part of the lung. It improves perfusion and clearance of secretions as well. Intubation for COVID-19 patient is relatively difficult, risky, and complicated process, as you will have to go through multiple layers of preparation, which we will talk about, and it's very, very important to take all the precautions and have good planning if you have the time to plan, and also have everything in process ready, so if you have to do it more emergently, you are prepared. You really have to make sure everything is done the right way. You have to have obviously full personal protective equipment. We prefer to use the PAPR when you intubate the patient, use the viral filter, and use the glycoscope rather than using the regular laryngoscope. Try to minimize the number of people in the room. For the people you need, the RT, the nurse, and the physician. Make sure all the drugs are prepared in advance, all the equipment are available. Evaluate the airway carefully before you start. Use a closed suctioning system, and have everything ready as you enter the room. So make sure that the communication done in a clear way, and use the intubation should be done by the most experienced practitioner. Some people use the BiPAP mask for pre-oxygenation, using 100% oxygen. If you end up using a regular mask, make sure there is a tight fitting mask with 2 hands grip to minimize leak. We recommend using paralysis to avoid coughing, which can increase the risk for acquiring the infection. And use a rapid sequence induction and avoid back mask ventilation when possible. And try to maybe clamp the tube and connect it right away to the ventilator right after you intubate the patient, rather than bagging the patient. In general, we recommend intubation if there is a rapid progression to over hours. Some patients, they come, they are already like on few liters of oxygen, and within a few hours they're already on 100%. So these are the patients that you really should consider possibly intubating if they continue obviously to deteriorate. If there is no improvement on heated high flow nasal cannula or non-invasive ventilation, or if there is evolving hypercapnia, increased work of breathing, and worsening mental status, and obviously if there is a hemodynamic instability or multi-organ failure, there's another indication, and that probably applies for most of other type of diseases. So unfortunately, what we saw that COVID-19 patient, they desaturate Initially, they may gradually desaturate, and all of a sudden they have sudden and deep desaturation. So keep that in your mind. After intubating the patient, try to use low tidal volume, 6 milliliter per kilogram of ideal body weight. Targeted plateau pressure less than 30, PEEP 10 to 16. If the patient does not respond to the standard ventilation, then you may have to use rotoprone bed or do manual proning to see if that would help oxygenation. You could use epoprostenol, the data are not that strong. Use paralysis such as Nembex. And obviously we use a steroid for severe ARDS, but now actually we with the recovery trial recommending dexamethasone 6 milligram daily. I think in these patients, rather than staying 10 days, you may have to continue beyond that if you have severe ARDS. And finally, when everything doesn't work and the patient continues to deteriorate, you may have to consider ECMO in certain conditions, such as like young patient with really no multi-organ failure and other things like that. In general, we recommend early proning in severe ARDS with COVID-19, and we actually prefer to initiate proning prior to use of the continuous paralysis. Obviously, if you cannot achieve the synchrony with the ventilator, you may have to start the Nimbex drip right before the prone. We recommend also initiate proning whenever the patient requires an FiO2 above 60% to achieve saturation above 92% or PO2 above 65, with the PO2 to FiO2 ratio less than 150, and that is prior to trying any vasodilator trial. The only absolute contraindication or contraindications for proning are spinal cord injury, open chest, and unstable airways. Having high BMI or the size of the patient is not absolute contraindication. We do recommend prone 16 hours per 24 hours and supine 4 hours every 24 hours. Regarding pulmonary vasodilators such as epoprostenol, there's really no clear evidence, no evidence of survival benefit of inhaled vasodilators in ARDS, and sometimes actually can demand significant respiratory therapist resources, which, as you guys know, it's a very tough right now to recruit or have more RTs, as they've been overworking and understaffed. There was a lot of controversy about whether BCG vaccine has any effect on COVID-19 protection. Some people kind of explained why we don't have a high mortality in countries in Middle East or Asia, because the routine use of BCG vaccine for TB vaccination. We really don't have evidence of that. There is no scientific evidence to support that. Right now, the World Health Organization recommendation that BCG vaccine is used for COVID-19 only in randomized controlled trials. Actually, there is a short supply of BCG vaccine, and we don't recommend giving it right now to induce or boost immunity for COVID-19. Whether BCG will be effective is not clear. There are some ecological studies suggesting in some countries with a BCG vaccination may have less chance of getting the disease, but I don't think this is accurate. I think it's a matter of time before the disease will reach and become more spread in these countries. It is also very unlikely that BCG vaccine will give that immunity that would last from childhood until adulthood or late in life. and also, like, I don't want to provide like a false sense of security that if you have if you had BCG vaccine that you're immune from COVID-19. So MMR booster is used to obviously to prevent the mumps, measles, and rubella. But there is actually mounting evidence that live attenuated vaccines provide non-specific protection against lethal infections unrelated to the target pathogen. It's very much you're kind of training your immune system. There are studies about using, MMR booster shot to induce a kind of higher level of immunity, especially for healthcare workers who are at high level of exposure. Do we need to use antibiotics for COVID-19? Well, there are some protocol that includes obviously the hydroxychloroquine and Zithromax. There is really no data, no benefit of using Zithromax so far. Or combination of Zithromax and hydroxychloroquine. I know WHO pulled the plug on hydroxychloroquine. I know it's been still used in countries like India, Brazil, and very limited use in the United States. The FDA removed the emergency use for treatment of COVID-19 with hydroxychloroquine. For other antibiotics, I only use them if there is evidence of secondary infection. Like we had one patient who had Streptococcus pneumonia and COVID-19. We had MRSA pneumonia and COVID-19. Then you can use the antibiotics as treatment for the bacterial infection. Let's talk about COVID-19 and pregnancy. According to most experts, having COVID-19, maternal COVID-19 alone is not by itself a reason to alter the standard indications for C-section or cesarean delivery. The CDC recently they updated their guidelines. They did a surveillance report and they found that pregnant women were more likely to be admitted to the intensive care unit, 1.5 versus 0.9%, and receive mechanical ventilation, 0.5 versus 0.3%, than non-pregnant women, but mortality was not increased. So more likely to have severe disease, but not more likely to die. The clinical manifestation of COVID-19 in pregnant women are similar to those in non-pregnant women in general. If you are practicing an area where the disease is prevalent, such as now in Florida and Arizona and California, we believe testing all patients upon presenting to labor and delivery is indicated and reasonable if it's available. In cities with a high infection prevalence, a high proportion of asymptomatic patients has been reported, about 13.5%. So it's I think in our hospital we've been doing that for a while. Infected women with COVID-19, especially those who develop pneumonia, they appear to have an increased frequency of preterm birth and cesarean delivery. The complications are more likely to be related to the severe maternal illness. So the more severe the disease, the more likely you're going to have obviously more complications. We're not sure about the intrauterine infection. It's still under investigations, although a few early newborn infections and placental infections have been reported, which suggested that it's possible but rare vertical transmission. How about COVID-19 and skin manifestations? Well, it's a viral infection, so like any other viruses, you may have a skin rash. It's actually identified in about up to 20% of COVID-19 patients. Some of that, it may be caused by the virus itself. Some of that could be related to immunologic response. You could have purpuric eruption. You could have livedo reticularis, which we see it in other diseases and sepsis. some of the manifestation could be related to vasculopathy, which could be associated with the COVID-19 infection. You hear a lot about the COVID toes, which are the discoloration of the toes here, and they are non-specific. They are not unique to COVID-19, but they could be related to also vasculopathy. The livedo reticularis, which you see here, also not specific for COVID-19. In general, there is really no specific manifestation skin-wise that you can look at and say, hey, this is for sure COVID-19. By now, most of us now are aware of the connection between diabetes mellitus and COVID-19. There is a national health study in England that showed people with the type 1 diabetes, they have 3.5 times more likely to die than non-diabetic patients with COVID-19. For type 2, it's about twice as much. The connection, is not just with the diagnosis, but also how severe the hyperglycemia or how poorly controlled is the diabetes. So if your A1C higher than 7.5, the higher the number above that 7.5 mark, the more likelihood that you're going to have a higher morbidity and mortality. Also, we know that patients with diabetes have increased risk for severe complications, including ARDS. And if you look at the patients with COVID-19 pandemic, 20 to 50% of them, they actually have diabetes. How about obesity? Well, we know that fat tissues, adipose tissue, they have a higher level of ACE2 receptors expression. So maybe that explain why these people are more vulnerable to COVID-19. We know by now that obese patients, they have worse outcome with COVID-19, including death, mechanical ventilation, and respiratory failure. A large study, over 4,000 patients with COVID-19 in New York City, found that severe obesity was major risk factor for hospitalization, only second to age. The mechanism could be different things besides the expression of the ACE2 receptors in the adipose tissue. We know that obesity can affect respiratory function and can cause respiratory dysfunction by impairing respiratory mechanisms, increasing airway resistance, impairing gas exchange, and causing low lung volumes and low muscle strength. Also, patients with obesity very likely to have other comorbidities such as diabetes, kidney disease, and cardiovascular disease. And also there may be a metabolic risk associated with obesity, including hypertension, insulin resistance, and hyperlipidemia. All of that could lead to severe COVID. So now we have Dr. Fauci. In 1918, they have Dr. Tuttle. And the lessons of history never learned, unfortunately. They did have controversy about wearing the mask, about public health messages, and they politicized the response to the pandemic at that time in 1918, and we were doing that now, unfortunately. So I do encourage you to read or watch the documentary about the 1918 Spanish influenza pandemic. Unfortunately, we are dealing with more than one pandemic. We know that COVID-19, we've been dealing with it since March, but we have been dealing with other problems for a while. We have obesity problem in this country and probably in many parts of the world as well. And that is actually increasing the risk for many American people for severe illness, as we demonstrated before. 34% of our population between age 20 to 40, they have obesity, goes up to 40% between 40 to 60, and above 60 is about 38%. On the other hand, we have also the racial disparities in healthcare. That has been the case for a long time, and unfortunately, even in 2020, this is still there, and it was unmasked, revealed clearly with the COVID-19 pandemic, with the number of deaths in minorities, and the difference in public health and access to healthcare system. And we also have a big problem with infodemic, which is the fake and false information that are circulating even from high level areas in our country. These information are many times can be misleading, can be dangerous, especially in the middle of pandemic. Rather than having a clear public health message, we have many people, many leaders politicizing the public health message, which is creating at least confusion, but also divide, and making the job for many public health officials, many governors, many physicians, nurses, making their job much more difficult. So we really have to deal with all of this together in this country, and I hope we can work together to really overcome all these obstacles. The challenge of the COVID-19 pandemic, as bad as it is now, it's not new. Humanity faced with multiple pandemics throughout history, and the majority of these pandemics actually have originated through the cross-species transmission of organisms from animals to humans. For example, HIV infection, originated from hunting and butchering of wild non-human primates in the early 20th century, which led to the introduction of simian immunodeficiency virus into the human. We also know that deforestation and climate changes may be behind the emerging of the Nipah virus from fruit bats to pig livestock and then to human. So even in the modern days, we know that MERS, for example, that was reported in Saudi Arabia during this millennium, it was the source was from camel. We know the SARS-CoV-1 or SARS came in 2002 from bats to human through intermediate host. So this is not completely new. It just, I think, it's larger scale. It's affecting the whole world, and it's very contagious, affecting many. So currently we have about 155 vaccines in one stage or another of clinical trials. In human trials, I think we have about 26 vaccines. These are some of the examples. Lately, the most recent news from the Oxford vaccine, which is adenovirus based vaccine. It's very encouraging. They had really good immune response, and the side effects in general, they were mild. The other vaccine that made it to the news lately, also the Moderna vaccine, which is mRNA, a messenger RNA vaccine, relatively newer technology, and also encouraging results with limited side effects and good immune response. The Oxford vaccine now in phase 3, Moderna by late July is going to be in phase 3 as well, and both vaccines are expected to go into production possibly by the fall, and maybe start to be ready by the New Year's. There are some reports that Oxford vaccine may be ready by September, but I think this is very ambitious. The US government made also a deal with Pfizer to have also a significant number of doses of vaccine available. I think they are going into phase 3 in July and August. So there are a lot of people working really hard to get the vaccines ready by early 2021. Now, remember, making vaccine for any disease, something usually takes years, and they are trying to squeeze it in 6 to 12 months. So just to give you an idea about where we stand right now, we talked about that. We have 155 coronavirus vaccines are under development. We have some of them are already in clinical trials. As you can see, in phase 1, we have 14 vaccines, in phase 2, 11, and phase 3, 4. In phase 1, the vaccine is being tested for safety and dosage. In phase 2, we have a larger number of people being tested to expand to evaluate for expanded safety. And then phase 3, the vaccines are used now or are used in large scale efficacy testing, and we have about 4 right now in phase 3. Now, there is the operation, what you call RAP Speed. The US government Operation RAP Speed is a program expected to name 5 or more vaccine projects to receive billions of dollars in federal funding. And the idea is to create combined phases in a way that you can actually have 2 to 3, like a phase 2 and 3 together, and maybe production at the same time, so you can accelerate the vaccine development. One of the vaccines that I am excited about, and I'm hoping to see really good results in the near future as it's entering phase 3, is the mRNA vaccine that is being developed by Moderna and the National Institute of Health. This is using a modern technology, a relatively modern technology, the messenger RNA. So rather than using the whole virus, you're using a part like messenger RNA. We'll show you some demonstration of that. So obviously, you start by isolating the virus, which was already done in China, get the genetic sequence, and then upload it in the database. And then the scientists were able to isolate the genetic information that's responsible of making the spike protein. These genetic information then sequenced and encoded in a messenger RNA. That messenger RNA is the core of that vaccine now, and the vaccine then will be injected in the human like any other vaccine. Then after injection, the messenger RNA will go to the lymph nodes, will go inside the cells, will translate into spike proteins. So it's almost like the virus is infected. As a result, the immune system will react and start attacking and the spike protein, and acts as if the patient is infected with the virus. So rather than injecting the whole virus, you're just injecting messenger RNA that will encode part of the virus. Remember that the spike protein, is responsible for the entrance, the entry of the virus into the cells. By creating immunity to this spike protein, you're really preventing this virus from entering the cells, and then will probably stop the virus from replication and infecting the host. So the important question about whether we will be able to get rid of COVID-19 is still really hard to answer. I know we talked about all these vaccines and the good news with the so far the phase 1 and phase 2 trials, but the question is, are we going to be able to get rid of COVID-19, or maybe just control the virus in a way that it would not be as a threat? So it may become endemic, like it may come every season or every year. So the first scenario, the first wave, is followed by a series of repetitive waves that occur through the summer consistently over a period of 1 to 2 years, will gradually diminish in 2021. I think so far this is more likely, as we have been observing over the last couple of months. The scenario 2, the first wave, is followed by longer or larger wave in the fall or winter of 2020, which will require mitigations measures to be reinstated to reduce the spread. That is a big possibility, especially with what we see so far in US. And then the third scenario is the first wave is followed by a slow burn of ongoing transmission. This scenario is becoming less likely as we have seen the re-emerge of the virus in many of the places that they had it under control. Thank you. So we need a roadmap. There has been a lot of confusion, a lot of divide. I like what the American Association of Medical Colleges, what they did. They had a way forward on COVID-19. I think a lot of these items are very, very important. We need to make sure we have adequate supply. We need to make sure we have enough medications every single day, like when we do our meetings, when we go cover the ICU, we hear about something, and we're really concerned whether we're going to have this medication or that medication available, or even like central line or basic ICU supply. So we really need to make sure we have everything available, and if not available, we need to find a way to manufacture it and make it in this country. We have also to have we need to have adequate testing. Testing has been a problem from the beginning, and even now there are many areas where testing takes more than a week. And remember, any test that takes more than 24 hours, it's almost useless from public health standpoint, from limiting exposure and contact tracing, making it much, much more difficult. The problem is, as I said, it's not just the availability of the testing, the speed of the testing, availability results. We need to have a national standards on face covering. We need to stop politicizing the face coverings and have a national mandate or national standards. We need to enforce national criteria for local stay-at-home orders. So this should not be, one state would do it, the other state would not, and then we find out that people are moving around. So there has to be some national criteria. Unfortunately, I think last time we did have some national criteria, but no one followed that. For school reopening, we really need also national criteria, which we are lacking right now. We need expanding health insurance. Many people are worried about access to healthcare. We need to plan for and prioritize for distribution of the SARS vaccine and making sure we are doing that in a transparent and in very informative way. We need to work on resolving healthcare inequalities and inform, educate, and engage the public. The problem with COVID-19 is not just obviously the disease, the morbidity, the mortality, the effect on the economy, the effect on our daily life, the political atmosphere that is very tense. I think the biggest problem, in my opinion, that the challenge that facing the humanity, the hunger virus. There are some estimates, a kind of scary estimate, that as many as 12,000 people could die per day by the end of the year as a result of hunger linked to COVID-19. Not because of the disease, it's just because of other things related to the disease. 121 million more people could be pushed to the brink of starvation this year because of the mass unemployment, disruption of food production, supplies, and declining aid. Finally, I want to spend the last minute here talking about the role of physicians in fighting this pandemic. The public, they look up to us and they expect us to lead in this fight against this virus. So we need to make sure we have the right message. We need to educate the public and provide them accurate and clear public health message. We should not engage in spreading misinformation based on our political beliefs, our religious beliefs, or any other beliefs. We have to use scientific and evidence-based approach to treat patients, regardless of how much pressure we are facing from others. Remember that pandemic anywhere is pandemic everywhere. We should actually focus not just to treat this pandemic here or eradicate the pandemic here, but actually globally. We have to work with our colleagues across the world in this fight. We have also to work together to end healthcare disparities. And we should insist on transparency and ethical approaches when it comes to research, guidelines, vaccine developments, and distribution. Thank you so much. Please note I tried my best to include the most up-to-date information in my slides. As this is really changing situation, I want you to be aware that some of these recommendations, guidelines, treatment most likely will change in weeks or months to come. I will try to update the slides maybe in a few weeks or every few weeks with the most latest information that we have. Thank you.